Thank you so much for that kind introduction, Colleen. And you had a rose. I just want to let everybody know I'm wearing my Valentine's Day jacket. And I hope you can see the color of it. It is a Valentine's Day color. And I also want you to know that this is probably my favorite subject, the history of Medicare in Canada. And currently I'm working on a book, which I hope to finish by this summer, on the history of Medicare. So this comes at an absolutely great time. So thank you very much for the invitation, Colleen. And I thought I would just briefly give you an overview. First of all, I'm sure that many of you, like me, when you were in high school, there was this tradition of giving each other Valentines, and they were generally rhyming or funny Valentines of a certain type. And this Valentine of "We Belong Together" would have fit right in to what we used to do in high school. And I think it does really fit in with this idea of Medicare as a romantic relationship. And romantic relationships, like all relationships, have a life course. So today, after I briefly describe and define what Medicare is, I'm going to go through that relationship in terms of its stages: young love, striving years, the best years, the hard patch, and the current standoff. And then speculate a little bit in terms of the future at the end, if there's time. So that's what you're going to be getting today. And I'll start with a brief definition of Medicare. And the reason that I have to do this is there's always a great deal of confusion about what Medicare is. And often the term Medicare is used as synonymous with healthcare, but it's not. It refers to a subset of healthcare services. And these are the universal health coverage programs and the services that are provided under those programs that are administered by provincial and territorial governments under broad national standards that are legislated and enforced by the federal governments, as well as more specific provincial and territorial laws and policies. And Medicare, as we know it in Canada, was established in stages, very discrete stages. And basically, it involves, and I'll describe this term a little bit more, single payer and single tier health services that we have access to on a first dollar basis, in the sense that we get full coverage. We do not have to pay anything at the point of delivery, but these services are defined in terms of hospital, diagnostic, and medical care services, which in some senses, medical care refers to physician services for sure, but it also is shorthand for primary care services. Then in addition, you have some other things like inpatient drugs, that is, drugs that are administered within hospitals, and some surgical dental services as well. Universal health coverage, therefore, you can see, whether it's Canadian Medicare or you're looking at universal health coverage in other countries, is a subset of all healthcare services. And you can see it in this World Health Organization cube, where the blue area defines the universal health coverage services, hypothetically. We would have something very similar for Canada if you drew this, except that it would cover basically 100% of the population. But the services that would be covered would be a very narrow band of services compared to a number of other countries, but it would be deep in the sense that it would not have any cost sharings or fees associated with it. So when you look at the Canadian system, you can look at it in terms of layers in a health system, with Medicare being one layer of that system. So if it's a 3-layer cake, Medicare would be the bottom layer. There's 100% public funding for these services, and all of the funding comes from taxation. So it's quite different than the other 2 layers. You have a number of mixed services that are offered by provincial and territorial governments. They subsidize or provide some funding for those services. You can see that in terms of prescription drug programs. There are provincial programs. There is a fair amount of activity in terms of home care and public funding of home care, but there's also a fair amount of private funding and delivery of home care. Long-term care is similarly divided between public and private. And then you get into strange areas like mental health care, where anything involving psychiatrists is under Medicare, but anything that might involve psychologists is privately paid for and therefore part of the private system, or occasionally is included in primary care through the public system in some way, and those services therefore are funded or subsidized by provincial governments. So that's the mixed category. And then the final category is the private category, and Canada is very extreme in terms of virtually all dental care services are in that private category. This just gives you a political organization chart. And the only thing that I want to emphasize here is a lot of the heavy lifting is on the right side of this chart. The provincial and territorial governments are responsible for the administration and the delivery of Medicare services. And this is, though, governed through the Canada Health Act at a very high level, but then provincial and territorial governments have their own laws, regulations, and policies that really determine the shape of these services and the rules surrounding them. As Canadians, we play and wear very different hats, and we need to approach this knowing very well which hat we're wearing at a given time, but we're all citizens, but we can also be users of the system, patients, directly consumers in that sense, but we're also caregivers as voluntary caregivers for people that we're taking care of. We're taxpayers, but we're also voters and political activists. And as many of you on today's Zoom session will be, you'll be students and researchers. And these hats imply a great deal in terms of how we look at the system. So today, what I want to take is more of what I would call a user and taxpayer perspective, as well as a voter perspective on Medicare. And the reason that I emphasize that is it's important to remember that Medicare, because it is 100% publicly funded, it is democratically governed through our political system. And it's largely done at the provincial and territorial level. So whatever province you live in, you will have a provincial health card, and it will be that premier minister of health and cabinet that will make the ultimate decisions in terms of your healthcare system. But you will have the opportunity through either your organizations, if you belong to a pro-Medicare organization or an anti-Medicare organization, to try and influence the decision-making of those governments in question. And we'll talk a little bit about venues beyond that democratic system, and that is the courts, and the use of the courts as an alternate venue in terms of trying to influence the direction and shape of the system. So now we'll start with our relationship and the various stages of the relationship, and I'll go right to the beginning, to Tommy Douglas and his victory for a social democratic government in 1944 in Saskatchewan, and the decision to try to set up a system of comprehensive health coverage for all services. That was the intention, but that intention had to be reshaped given the realities of the time. The first reality was that there was considerable hope initially that the federal government would play a much larger role. And in fact, there was a major conference held at the time called the Dominion Provincial Reconstruction Conference that was attempting to set up what I would call fairly comprehensive welfare state involving very comprehensive health insurance. The federal government would pay at that time, based on the proposal, 60% of the costs of the provincial and governments insuring coverage for all residents. The provinces at the time were divided, quite frankly, as to whether they wanted to get into this or not. But Saskatchewan was very much a proponent in favor of it and led the group that wanted this conference to be successful. It failed. And as a result of that failure, the government of Saskatchewan decided to go ahead on its own with universal hospital coverage. In 1946, it passed the law in the hope that when it implemented, that the federal government would eventually come back to the table and offer shared cost funding for the program. It was a very effective program from the beginning. Many governments came to watch it in operation. It actually was implemented a year and a half before the National Health Service. There really was no similar single payer system in the rest of the world, so it had to set it up on its own. It got the best help it could get in doing that, and it turned out to be effective. British Columbia adopted the same program in 1948. Alberta adopted a different approach. Instead of the single payer and single tier system that Saskatchewan adopted, it adopted a multi-payer and multi-tier system. And I will talk a little bit about those terms later on. That was then followed by a national adoption of the Saskatchewan model through the Hospital Insurance and Diagnostic Services Act of 1957. But you had a very reluctant prime minister and cabinet at the time, Louis Saint Laurent, and a Liberal cabinet that did not want to go very far, and in a sense were goaded into adopting the legislation, partly because they were facing election at the time. But the reality is they were less than keen. And one of the ways in which they designed the legislation was something called the double majority rule. They would only, in a sense, implement the Hospital Insurance and Diagnostic Services Act and offer shared cost funding if a majority of provinces with a majority of population in the country would agree to it. And of course, at the time, it was very difficult to get that kind of an agreement, particularly with the province of Quebec, which was offside at the time. Its government was more conservative in nature. It was not keen on it. Government of Ontario wanted certain issues dealt with, including a very different kind of a design that it wanted accepted. And those being the two largest provinces could have blocked forever the adoption of the Hospital Insurance and Diagnostic Services Act. So on the right, you see the gentleman that's standing up in the House of Commons. That's John Diefenbaker. He ended up winning the election of 1957. And in the campaign, he said he was going to do something about the double majority rule. And he did. He basically dropped it, allowing the provinces to adopt when they were ready, beginning implementation in July 1958. And by 1961, all of the provinces were in the system, including Quebec, which joined after Premier Lesage and his Liberals were elected in Quebec and brought a modernizing approach to government in Quebec, including a desire to implement a welfare state, including universal hospital coverage. The next period of the striving years, and here this is the very difficult middle part of Medicare, the relationship 1960 to 1972. This began after universal hospital coverage was adopted nationally, and the federal government decided it would provide shared cost funding. This allowed the government of Saskatchewan to then extend its program to medical care. In other words, physicians, and not just hospital stays. And it basically was in a battle with the College of Physicians and Surgeons of Saskatchewan, Organized Medicine, over this issue. The regulatory body at the time was twinned with the Medical Association. That had been done to save money in the 1930s. And so you had a very powerful body that combined these two functions that opposed the idea, and they were joined by the Canadian Medical Association that was against the idea of single payer and single tier medical care coverage, as well as the American Medical Association. So the election of 1960 in Saskatchewan became effectively a referendum on Medicare. The Douglas government won that referendum, but the physicians continued to fight against the idea of it. They said that they were not against the idea of some government support, but that it had to come through subsidizing private insurance premiums, and that it could in no way affect the way in which physicians were practicing medicine. The government went ahead with it, passed the bill in 1961. This triggered even more opposition among the physicians. And then in July 1962, you had a 23-day doctor strike that resulted in basically a shutdown of services through the province for 23 days, with some emergency services being provided by doctors. The strike only came to an end through a compromise by the government and by the doctors. The doctors had to accept Medicare, but in return, the government had to accept the business model of the doctors, which is basically fee-for-service practice, as well as a few other compromises. And that compromise then became the template for the rest of the country in terms of how Medicare was introduced. By the end of the 1960s, doctors across the country had come to a grudging acceptance of Medicare. But in part, they were able to accept Medicare because their own remuneration went up quite considerably in the first few years of Medicare. And that was partly because they did not have to collect unpaid bills anymore. And their business increased because there had been a lot of pent-up demand for their services, but because people could not afford those services before Medicare, they could, after attend doctor's offices, go and see doctors, and as a result, their income went up quite considerably. The pictures that you see below, one is of the demonstration in front of the Saskatchewan Legislative Building in 1962 during the doctor's strike, and the other is the kind of sign that was posted on doctors' offices to make it clear that they were on strike and would not be providing services. Nationally, the government, of course, the federal government saw what happened in Saskatchewan, was not keen to be at the receiving end of that kind of polarization. But at the same time, the federal government had received a Royal Commission report from Emmett Hall called the Royal Commission on Health Services, which had recommended basically the same type of coverage that was provided in Saskatchewan in the same design, a single payer and single tier. Emmett Hall and his commissioners recommended this based upon what they felt was the best, lowest cost kind of approach based on the practicality of implementing it, not based upon their ideological proclivities. In fact, Emmett Hall himself was a conservative and certainly wasn't attracted to the Saskatchewan program for ideological reasons. The Prime Minister at the time was Lester B. Pearson, and he was very much torn between, on the one hand, the folks in his cabinet that were very much in favor of implementing universal medical care, and a very powerful group of liberals that were against the idea entirely, both for financial reasons and for ideological reasons. They also preferred to see a kind of a subsidy approach in which government would provide some funding to people who could demonstrate that they couldn't purchase premiums, private health insurance premiums, and if they passed the means test, they would get some government subsidy to purchase private health insurance. Pearson eventually chose sides and decided to go the way of the Saskatchewan plan. And as a result, the Medical Care Act of 1966 set out those principles very clearly. And the principles that we have today in the Canada Health Act, 4 of those 5 principles were already embedded in the Medical Care Act of 1966. And now we move on to the golden years, the 1970s and 1980s. And in fact, by 1990, the end of this period, there was a survey done of Canadians, and the vast majority of Canadians were very much in favor of their health system, very satisfied with their health system, and felt that it was better than any other health system in the world. And these results were quite striking, given similar surveys in other countries that showed higher degrees of dissatisfaction. So that was probably the highest point of our satisfaction with the way things were in Canada. So what were the elements of this relationship at that time? Well, first of all, Canadians always compared themselves to the United States, and Medicare was the major departure point with the United States. You could see that we had better access. You could see that we had better health outcomes as well as medical outcomes. And we were not yet very concerned as citizens about the narrowness of Medicare. Healthcare seemed to be mainly about doctors and hospitals and the drugs we received inside hospitals, and not about too much else. The second dimension of that was that, yes, individuals benefited from Medicare and for selfish reasons would support it, but based upon surveys done at the time, what became obvious is that there was a lot of loyalty built up for Medicare because there was a satisfaction in knowing that your neighbors, the people in your community, were also protected through Medicare. So this went beyond that kind of narrow self-interest of protecting yourself and your family, that this moved beyond that to your community and beyond the community to the country as a whole. As a consequence, Medicare became the heart of national identity and a national unifier in the country. And I think that set Medicare off as a kind of a privileged public policy in the country. And it meant that it was so important to Canadians that later on, this would have a kind of a dual impact. And we'll talk about the defense of Medicare on the one hand versus the attacks on the concept of Medicare on the other, and the kind of polarization that has generated. This was followed by the passage of the Canada Health Act and the 5 principles, but there was really only one new principle. All of these other dimensions actually existed in the previous Medicare laws. So the Canada Health Act did not do much that was new, except that it ensured that it discouraged to the greatest extent possible user fees in other provinces. That is, physician extra billing, as well as user charges by hospitals, et cetera. That had been a little unclear before that time. And the Canada Health Act made it very clear that if provinces permitted those practices, those provinces would be penalized dollar for dollar, the amount that they allowed for user fees. And again, there was no prohibition. It was just a kind of a disincentive effect that was used. And the minister at the time, Monique Bégin, was brilliant in the way that she designed it, in that she promised that if provincial governments could get rid of all of their extra billing and user charges within a period of 3 years, that they would be refunded the full amount that they had been in effect charged by the federal government and deducted by the federal government. And this was quite effective in getting provincial governments to move, to alter, to deal with their hospitals, to deal with their physicians. And in some cases, they passed laws that actually prohibited the user fees. So that brings us to the hard patch of the relationship from the 1990s to, and I cut it off at 2004, but you could say it's right up to the present if you wanted to. This began with very serious cost cutting of the provincial and territorial governments in the early to mid 1990s. This cost cutting had 2 impacts. One was to force otherwise difficult reforms that were probably quite positive, but it also did damage to existing infrastructure as well as human resources. And as a consequence of that, service quality and the timeliness of service changed quite dramatically. And by the late 1990s, everyone was unhappy, even though there was beginning to be new reinvestment in the system by 1997, 98. And this unhappiness was right across the board. You had citizens and taxpayers that were unhappy. Taxpayers felt they were paying too much and not getting enough value. Citizens unhappy because of lack of access at times. Providers were unhappy because they seemed to be under a great deal of pressure and they didn't have the appropriate resources at time to provide the quality care they felt they should be giving their patients. And federal and provincial governments were at each other's throat over this period. Part of this was that the federal government reduced its main health transfer, and the provincial governments used that to attack the federal government. It was unhappy. I mean, provincial governments were unhappy at the federal government on a number of fronts, but they used that in particular to attack the federal government. And they used the health transfer as a way to get the federal government to reinvest in transfers generally to provincial governments. And in the midst of that warfare, the Romano Commission was set up. And as mentioned, I was the executive director in the Romano Commission. So I was at the sharp end of the pointy stick for 2 years and dealing with this federal, provincial, territorial warfare while trying to work on a report that would address the issue. And in fact, the report was forced to make recommendations that would, in a sense, try to move the system one way or the other. And in the case of the Romano Commission, it was decided that to expand universal health coverage was the right way to go. It was the more sustainable way to go, and it would ultimately produce an impact that would improve quality, et cetera. There were many in the country that argued the opposite at the time, and the report was delivered in quite a polarized environment. Prime Minister Paul Martin in 2004 made a deal with the provinces that he thought would basically create peace in our time. The problem with the deal is that while it flushed a huge amount of money into provincial coffers, it did not change any of the dynamics in Medicare, nor were there any requirements in terms of the money to, for example, expand universal health coverage, et cetera. So it was a lot of money for very little at the time. And there's been a huge question mark ever since, because it was the one point in our history where the money would have been available to have moved forward with universal health coverage, and the opportunity was lost. So that brings us to our current standoff, where we continue to be paralyzed on the question of Medicare, or as some authors in Canada have referred to this as a paradigm freeze since the 1970s. The majority of Canadians still support Medicare at the level of principle, but they're increasingly unhappy about Medicare in terms of its actual management and the service delivery. When we have time in the questions, we can go over some of those concerns. As a result, there has been an anti-Medicare coalition that's been growing in strength, and it is relying on venues that are very different than the one of trying to influence government directly, and that is, for example, an increasing use of litigation. This kind of an approach, because it has to be funded in some way, favors the well-funded. And governments have been rather responsive rather than proactive. They've been reactive, in other words, and they have not really dealt with this in a particularly constructive way. They've certainly dealt with the litigation, and they've been the defendants in the litigation, but they haven't used the litigation in a sense to pursue a broader objective in terms of Medicare, including its improvement. So let me end on this. Is Medicare worthy of love? Well, first of all, despite the strain and the commitment still is there in the relationship. And there's lots that would tell you that maybe you'd expect Canadians not to be as committed. Well, it's easy to explain in one sense. Canadians remain very committed to the principles of Medicare. including the 5 principles of the Canada Health Act. The majority of Canadians really want access to be based on need, not on ability to pay. But they certainly want improvements at the service delivery level, and they feel that things have gotten worse rather than better. This might come down to us putting this in terms of a relationship and the fact that there needs to be growth in any relationship, and it doesn't feel that Medicare has grown a lot in Canada. And while the relationship continues, this raises an existential question for us as Canadians. The most important of which is, can the relationship really endure in a post-COVID world? We have seen during the period of the pandemic a lot of what I would call the challenges of Medicare, particularly at that administrative and service delivery level. But we've also seen that some aspects of Medicare are kind of clunky and have not worked particularly well. It is a federal provincial program. It's not a single government program. You have the Canada Health Act, and then you have the governments at the provincial level working within that framework, but they provide their own detail on how to do that. During the pandemic, virtual care came on quite rapidly, and there were many providers of virtual care that were definitely providing medically necessary services that people couldn't get access to in any other way during the pandemic, but were charging for those services. And you had this division among provincial governments, some of which moved not quickly, but over a few month period to try to include those virtual care services as part of Medicare. Others that absolutely refused to do so and continued to, in a sense, expect people to go outside Medicare to access those services. And while that saved the treasuries of those provincial governments some money, it raised some larger questions about Medicare, and it undermined confidence in those Medicare systems by the residents of those provinces. So I only throw that out as an example. It's a small example. The question then is, what can break the Medicare jam in terms of this paralysis or this lack of growth? And I thought the Medicare logjam came close to being broken a few years ago through universal pharmacare, which would have been added to Medicare, but instead there's been a real retreat, particularly by the federal government, which refuses to even talk about universal pharmacare at this point, even though it put it in its platform in both elections. And you would think that it would be held to its promise. So that, despite need, this is not broken, the Medicare logjam. It may be broken through litigation, and it might be very negative at first, in the sense that the litigation would, in fact, create a private pool within Medicare, and we would have to respond to that, both as citizens on the one hand, and as government policymakers on the other, rather than just allowing the current situation to go on and on. I could go on forever about this. I think it's probably best that we leave that to the questions. What do you think, Colleen? And I'll end right now.
That's wonderful, Greg. So maybe we'll switch from screen sharing and go to, so if you stop screen sharing, I think we'll go to
all right.
Lovely, gorgeous. And we'll start with some questions that are coming in, but I think I might take the prerogative of the first question, Greg. And, the spur for a lot of discontent for Canadians and the spur for the constitutional challenges to public Medicare or single tier universal coverage is around accessibility and wait times in particular. But, I think across the country, many Canadians don't have accessibility to family doctors. They're concerned about long wait times for healthcare, and those concerns will be certainly amplified if and when we start to emerge from this pandemic with a lot of built up need. And as you well know, the Canada Health Act does talk about reasonable accessibility for Canadians, and not just in terms of the financial aspect, but it specifically says not just about that, but in other ways there has to be reasonable access for Canadians, but it doesn't define what that is. So I'm wondering, in your view of things, how can the federal and provincial governments, how can there be accountability for reasonable access to, some of the basic things, primary healthcare considered, a core piece, essential service by the World Health Organization, to primary healthcare for all Canadians, and to, some sort of sense of timely treatment, accessibility, wait times, things. So how do we square this problem? How do we deal with it, Greg?
Well, that's a huge question, Colleen. If I had the answer, I wouldn't be talking to you today. I'd probably be working somewhere else. But I'd say number one, the answer probably initially will come from outside government. It's going to be through public pressure. And the traditional public pressure through the electoral system clearly has not worked. Otherwise, I think universal pharmacare would likely be a policy by now. So we probably need to resort to other venues, and some of the citizen groups, pro-Medicare groups, may want to consider a much more aggressive strategy involving litigation and the use of the courts, and getting terms like reasonable access defined, and forcing some provincial governments to, in fact, provide that reasonable access. And I've seen things during the pandemic where governments have refused virtual access or access to virtual services, even though they were clearly primary care services, and some of them were even secondary and specialized care services that clearly come under the definition of the Canada Health Act as insured services, but said, no, we're not going to provide them. The federal government did not step in and say that was an infringement of the Canada Health Act. There was no citizen group to step in and to lobby the hell out of the government to say that, you're not living up to your responsibilities. There was a lack of accountability. Nobody could understand what was really going on. I mean, the general public here. So the venue of the courts is going to have to be a real possibility here. But the other is for the citizen groups to take a much more proactive strategy and not simply defend the system as it exists, but to be strategic in picking out areas where they want improvements and then litigating against the very provincial government that is defending an untenable status quo. Mm-hmm. And then I think it's up to those of us who are on the outside looking in, but as advisors, to begin to be very targeted in terms of the advice that we give or the kinds of things that we write in op-ed columns in newspapers and in social media about what governments can do in terms of greater transparency, for example. the lack of transparency is almost criminal. But it's something that we seem to accept in this country, and we have to create a culture where it becomes unacceptable.
You think it's sort of part of the problem of our love affair with public Medicare, you know, sort of like in relationships generally, you know, at first I'm so lucky to have you and I'm so committed, but then perhaps some of us have experienced this over time. You take me for granted. So I think we could probably write a series of novellas around relationships and public Medicare. But perhaps we'll come back to this question of accountability, and maybe Ian Chesney's question perhaps picks up on this. Greg, he'd like to know, do you think there is a better way that the federal government could fund Medicare other than through the CHT?
Yeah, I think that this kind of a mechanism is not particularly effective because of the fact that the money flows directly into the general revenue funds of the province and really can't be tracked after that. And it hardly matters to a provincial government, and I've worked there, I know that. It hardly matters to a provincial government how the money comes into the general revenue fund, because once it's there, you can use it in whatever way you deem through your Treasury Board process to allocate. So that's not a pretty effective way of expanding universal health coverage. Much more effective would be something that would be tied directly to it. It would be a highly conditional transfer. It would be a hypothecated fund, perhaps, that is segregated, where the money can be followed very carefully. That has a moral hazard associated with it because it creates incentives and disincentives that aren't always the most efficient in nature. But it's probably better than the alternative of the Canada Health Transfer. There's more than enough money to properly enforce our existing principles of the Canada Health Act through it's more the matter of whether we're even using that leverage at all. There's more than enough leverage. But the other way is to a social security mechanism, similar to the Canada Pension Plan, and some of our colleagues and you and others have suggested that mechanism be considered. In that case, it could be a direct program involving the federal government and the citizens of Canada. Or if you wanted the federal government setting out the general principle and it being administered at the provincial level. It doesn't really matter, but the mechanism is quite different. There are, of course, strengths and weaknesses to that approach, but I think, for example, that could have easily worked on pharmacare. And, we can have differences of view on this, but for sure, trying to do it through the Canada Health Transfer has a host of problems associated with it. And it may be one of the reasons that the federal government just can't see its way to doing it, because they feel like they're taking on enormous political and fiscal risk, and the payoff is absolutely minimal in terms of how that works out in practice. So I can understand that. So social security mechanism or a series of bilateral transfers with very tight agreements associated with them.
So just so I understand, Greg, because somebody here has also asked about when we would get universal pharmacare. You are saying here that that there is a potential political win should the federal government roll out directly some kind of pharmacare plan with its citizens, but not as much upside for it if it were to go the sort of normal course that we have in Fed-Prov relations. So some sort of Canada Health Act for pharmacare, some sort of transfer of funding to the province. Is that what you're saying? It wouldn't have as
well, I would say, I would say politically that's more feasible. I think that there would be more payoff for the federal government in the long term.
In the former or the latter?
The federally run program.
Okay. Yep.
I actually don't think that you could actually achieve federal pharmacare at all through a negotiated process now involving the provincial governments. Or if you were successful at the negotiation, the money would flow, but there wouldn't be any way to ensure that you would actually end up with universal pharmacare at the end of the day. The money certainly would get used.
Right. But so if you're, looking into your crystal ball, Greg, when and if will we ever see such a federally run pharmacare program?
Well, I don't, here's the hard part. Not with the current political culture that we have. Certainly the federal government that I dealt with here would never want to do that, because it would mean confronting some very difficult realities with a couple of the provinces, and it wouldn't be willing to deal with that. Second of all, it still raises the issue of fiscal risk, taking on 100% of the cost. Right. And I think there's a lack of desire to do it. And then there are the what I would call the arguments from some quarters that it's not within federal jurisdiction to do this, which I dismiss immediately, because if there's any area of healthcare where the federal government has a constitutional ability to get the work done, it's in this area. It in fact has more constitutional authority than the provincial governments in this area. But it's the only area of healthcare that does. It's the only area of healthcare, I think, that the federal government could act unilaterally. And I would never want the federal government to do so in an area such as home care, because that involves direct service delivery, and provincial governments are much better at that. This involves the administration of an insurance program effectively.
Great. Okay. So kind of along the lines of accountability, Bill Thole has joined us. Nice to see you there, Bill. And he raises the question about the Canadian Health Council. Many of us were keen on this as a measure to try to achieve better accountability mechanisms between the federal and provincial government. This was, in Bill's words, summarily nixed at the first opportunity by the Harper government. And he asks, are the PCHO agencies filling this accountability gap? So would you care to comment on that, Greg?
Well, there's two kinds of organizations. One are the intergovernmental bodies that are, receive a lot of federal funding, but they're still intergovernmental bodies and have intergovernmental governance. And then there are the foundations. And they're two very different animals. The Health Council of Canada was the former. It was an intergovernmental body. And it struggled to its feet. Only in the last couple of years of its life was it beginning to fulfill its mandate. But even then, I would say that it never had the power and the position to fully fulfill its mandate. And in the Romano Commission, we certainly made a recommendation. And in fact, a number of recommendations predicated on the establishment of a Health Council of Canada, but it was to have included the Canadian Institute for Health Information, as well as other attributes that would have made it a much a major player in terms of the country, and it never had that kind of infrastructure and ultimately influence. But that said, it was better than nothing. And in fact, in the last couple of years, was the only organization that provided Canadians with a degree of transparency into the system. And its reports were written to the Canadian public in a way that could be understood by educated members of the Canadian public. And I'm afraid the other organizations that we have, they fulfill niche roles, but they don't fulfill that larger health system role that was being performed by the Health Council of Canada. So we're really lacking it. And I must say that it created a huge vacuum, and I felt that we needed to create something in Canada outside of government to begin to fill little parts of that vacuum. And that was one of the reasons that the North American Observatory in Health Systems and Policies was created. But you would need a dozen such organizations dealing with a whole host of issues to be able to even begin to fill the hole that's been left by the Health Council of Canada.
Yeah. I think Joel Lection, who's here, who's in the audience as well. Nice to see you there, Joel. And thanks for your question. As you know, Joel's one of our leading pharmaceutical policy experts in the country, and I think his question is really behind it. Perhaps is how to garner support and drive towards a universal plan for pharmacare. He says, my understanding based on a 1965 poll, which is some time ago now, is that the Canadian public was largely split between a voluntarily public insurance plan and a universal plan. So I guess a voluntary public insurance plan being where one could opt into the public plan or otherwise keep private health insurance, and more of a two-tier system. He asked, can you comment on that division in the mid-1960s and how support grew? Finally, do you think that an expansion of Medicare would enjoy increasing public support over time?
Okay, well, on the first question, the love affair with Medicare during that, what I call the striving years, was very mixed. Everybody loved hospital coverage. It didn't threaten people to the same extent. And the doctors even loved universal hospital coverage because they didn't have to worry about getting their patients in the hospital. And it helped the patient to pay their own bill for their doctor because it freed up so much money. So it didn't create the same political dynamic, but Medicare did. That's the payment of physician bills. And the doctor's strike and the aftermath of the doctor's strike for a few years after, this issue of which system is better was very much in contention. And there was great arguments in the country about whether we should go with a single payer system or a multi-payer system. And at that time in 1965, the government of Ontario was setting up its subsidy system for private health insurance that it called Medicare, but it really was, I call it Robarts Care after the premier at the time, John Robarts. It was a Robarts Care system similar to the Alberta system, which was Manning Care. And these were all the same. These were multi-payer systems. And there was a real debate that went on, and it really did not end in the country until the end of the 1960s and the beginning of the 1970s, when everybody had some experience with Medicare and the single payer design. And they said, oh, this is pretty good. Oh gosh, do I ever like not having to deal with any insurance company? Oh, there's no paperwork here. And the doctor said, oh gosh, I don't have to worry about going through the insurance company. There's less paperwork. And they were happier with the system than they thought they would be. And so all of a sudden you had this split turned into what I would call a clear majority in favor by the 1970s of the kind of design that we had in the country. And then that turned into a deeper kind of love, if I can use the Valentine's Day expression, when people said, oh gosh, this really separates us from the United States. This makes us feel good about being Canadian. And you know what? I like the fact that I don't have to worry about what happens to my neighbor or friends down the road, that they're taken care of as well as I'm taken care of. And so, and the other aspect of that is that Canadians didn't live in a bubble. They understood, and the closest country, the United States, they also knew that it was very difficult to change jobs in the US for those that traveled to the US because of health insurance. Whereas in Canada, you could change jobs anytime. Second of all, the businesses in the country very much like the system because they didn't have to provide enormously for employee benefits in the form of medical and hospital insurance, like the business owners in the United States. So it made a huge difference in terms of their competitiveness. So by the 1970s, everybody was realizing the benefits from this system, and that sentiment went from a split, I think, to a clear majority in favor. And that there continues to be that majority in favor. I just think that now, and Colleen, you'd asked this question earlier, so I'm going to answer it now, is that we have this dichotomy where you still have a majority of Canadians in favor of the general principles, but they're increasingly unhappy with how the services are delivered, the attitudes of the people working within the system, and the lack of transparency, and the fact that they feel like they're hostages at time to the system.
Yeah.
And so there is this real tension, but this doesn't mean they want to throw out the principles. They don't want to throw the baby out with the bathwater. They want to keep the baby, but they want to change the bathwater badly.
Yeah. So Karen Palmer is in the audience. Nice to see you there, Karen, and thanks for your questions. She's asking a question about the disruptor of virtual care. And, with the pandemic, we have seen, a real revolution in virtual care, something that we were told was really impossible for all sorts of good and compelling reasons pre the pandemic turned out to be very possible when the need was there. However, it's raised many, many questions about how we organize our system and how we pay for our system. So she's asking a question around reciprocal billing agreement and whether it applies interprovincially when it comes to virtual care. So she mentions that physicians working for a popular virtual care company billing provincial plans for virtual care, but only during certain hours. Outside those hours, a patient in BC must or can pay privately for that virtual care provided by a physician in another province who does not have a BC billing number. The virtual care company claims that they are justified in billing the patient directly for care during these off hours. And she would like you to comment, if you would, on these interprovincial agreements in light of virtual care.
Well, there are about 10 questions buried in that question, so I probably can only deal with a few of them, and I'll deal with the ones that I feel a little more comfortable with, because there's a lot about reciprocal billing that I must admit I've been trying to learn for years, and I haven't figured all of it out. In fact, I haven't even come close to figuring out part of it. It's a very complicated system, as we all know. But the first thing is that going back to principles, there's nothing in the Canada Health Act and there's nothing in the provincial Medicare laws that says it's medically necessary if it's done within office hours. It's not medically necessary if it's off hours. So that clearly is a ridiculous distinction. And if this was to be litigated, I am sure that somebody interpreting federal and provincial laws would say, oh, this doesn't make any sense at all, and this would need to be changed. Second of all, our infrastructure for Medicare is at the provincial level. It's based upon an assumption that not only your patients are provincial residents, but your providers are provincial residents. And this causes, because you have to, in a sense, be regulated through your professional body in a particular province. Now, you can perhaps have more than one license, but most physicians only have one in their principal place of residence. And the assumption that we made about Medicare, which isn't in the Canada Health Act, is just one of the operating assumptions of how the system came together in the late 60s and throughout the 1970s, was that this would be the case. Virtual care blows that up. And it tells us that basically this assumption no longer holds. And we need to be able to redesign Medicare. And there's nothing preventing this from happening in the Canada Health Act. Canada Health Act is not an impediment. Provincial laws, for the most part, are not even an impediment. It's the operating policies and procedures that are the impediment. So you have to get the health bureaucracies and the ministries of health to, in a sense, work on a redesign to be able to deal with the fact that there are going to be providers who are not resident in your province providing services to residents within your province that are going to be using their health cards. And you have to figure out the system of reimbursement, et cetera. And you have to start from the premise that if they're receiving a medically necessary service, that's great. And it could be an advantage to those provinces who would constantly have problems with supply of physicians and particular specialties and in certain areas, where for virtually no cost at all, except for the payment of the patient bill, you can access a physician in another province. So in that sense, it's an opportunity.
Yes, yeah.
And should be viewed as that, but it's not viewed as that. I think it's viewed as strictly a cost factor. Second of all, it's muddied by the fact that there are private companies running these groups of physicians. And there are some who want to prevent private, what they consider to be private delivery. But when you look at the physicians who work within these groupings, these private groupings, many of them are people that are doing this on a part-time basis. And they're working within the system in the usual way, providing Medicare services. And then they're providing these other services because they can provide them from home. And all of a sudden they begin servicing people from outside their province. We're going to, I think the best way to deal with this is for the provincial and deputy provincial ministers of health to get together and to work on this together, because this is a pan-Canadian challenge, but it's also an opportunity. And they need to work out how they're going to, in a sense, refashion their billing, but also how to refashion their internal system to, I would say, facilitate some of that care so that people are not being queued up in the way that they are and can access care when they need it and how they need it.
So maybe a little related to this discussion, Greg, is a comment by Terry McGrath that recently I'm hearing that new young MDs are looking for salaried positions, that they don't want the hassle of self-employment and dealing with bills, but prefer to practice their profession hands-on. But also we have seen with a move to sort of capitation payments, and, you know, really generally over the last, 10, 15 years or so, more physicians in the public plan working part-time or fewer hours and then perhaps spending, other time doing Botox, cosmetic surgery, now, virtual care in other provinces that at least has some benefits, even if it's privately paid for. But do you have some views on this, the sort of right mix of payments mechanisms, and how do we make sure that the physicians working in the public plan, deliver on some aspects of ensuring accessibility for Canadians in return for the reimbursement they receive, whatever mix that is?
Well, the evidence is very, very mixed on this, but there's some tendencies within it. And the first is that fee-for-service works okay when it comes to highly transactional services, some of the surgical type services. But beyond that, when the services are not transactional, that's virtually all primary care, psychiatric care, and I could go on in the list, then fee-for-service is a very poor method of payment. It creates all the wrong incentives. So then it throws you into the alternatives, which is capitation for primary care based upon population of the patients you're suffering, with a formula attached to how sick they are, maybe, to straight salary, to blended forms of remuneration that involve all three different types, but really at different times. So after hours might be fee for service, but the rest would be a combination of capitation and salary. The best way to approach this is, instead of having a single system designed through a master agreement at the provincial level between the provincial Ministry of Health and the doctors, is that you permit your health organizations to adopt the remuneration system that best suits them, and they make the decisions. We had that opportunity when most of the systems were regionalized, had regionalized health authorities. Now, some of those systems have single centralized health authorities, not much different than a health ministry. So you're not necessarily going to get that kind of experimentation in those systems, like in Alberta, or even necessarily in a place like Nova Scotia. But you can still do it in most other places. And I would say devolve that to local decision makers who design the payment system based on local needs. And of course, there are doctors that would prefer to be paid salary. It just makes sense. Just like there are doctors that prefer to work for these virtual care companies because they take care of all the billing and all the other issues. They don't want to get into that. And so I do think that can change, but we need to allow this kind of differentiation at a local level go on, and we need to allow, I would say, experimentation, and excuse the expression, but let 1,000 flowers bloom, and then we will see very quickly what works and what doesn't work.
Well, we've sort of had quite a bit of different attempts with mixed payment systems of different varieties, and I just wonder, is there some possibility in here for use of more contracts or agreements or other mechanisms as part of the payment system to try to extract more value in terms of ensuring timeliness, accessibility, a little bit more like we sort of see in the UK?
Yes, there's lots of avenue for that. And even the contracts in the UK are not particularly onerous. And we could go very far in this area. The question is the politics of the double bed. Right now, there's a privileged position between provincial medical associations and ministries of health. And the Provincial Medical Association can nix that very quickly,
Right.
and because they may not see that there's any advantage to that. On the other hand, you also need actors on the other side in a contracting system that are sophisticated in terms of drawing those contracts up, monitoring them, enforcing them, etc. And we do not have that group of people in place, so that has to be developed over time. But yes, we should. That's exactly the direction we need to move in, because we're never going to get improvements in terms of that kind of both accountability and patient responsiveness without it.
So Sharini would like to ask you, from your extensive knowledge of the history of Canadian Medicare and the history of healthcare, is there any part of this history, that serves an important role for our modern day system? Or to put it another way, is there something that we must keep top of mind from the history to help guide us as we think about reform or our future in public Medicare?
Yeah, there's two things. Number one, our system was both contingent in terms of how it developed. In other words, it wasn't a foregone conclusion that it would end up being single payer and single tier, and it can change. So the one lesson to draw is that, we can change it. We can change it in positive ways. We can change it in negative ways. This isn't set in stone. The second aspect, though, is what we learned from history is that the people that created the system never intended it to be frozen in time. They intended it to be simply a step in a progress towards a more universal and comprehensive system, a better system.
Mm-hmm.
And we have, for whatever reason, come to the conclusion that they intended it to be what it was made, what it became in the late 1960s. And we have to get that notion out of our head, that the people that first formulated these ideas, pushed them through as senior leaders, would be horrified with the situation that we're in today. Mm-hmm. They would say, there's been no progress made. How can this be? We provided some foundation for you to build on, succeeding us in terms of the generations that came after, and you haven't worked with it. Mm-hmm. That's the history lesson that I take from this. So we got to quit thinking about this as in the static way that we do. We can't just defend the status quo. We have got to be proactive, and we've got to build.
Don't you find, though, Greg, I find this, when you start talking about the reform that we need, you're immediately push back on the ropes in the sense, well, the answer is privatization, that this is what needs to happen. And the court cases which we've been involved in, many have, of course, that have gone on for years. So it seems that it's very difficult to actually move forward on the reform agenda when one is so busy defending, the very kind of concept of public Medicare. And is there a problem with the expansion that, many would say we need to do in terms of pharmacare and in terms of improvement of long-term care and home care, when perhaps the public feel that the bargain, the so-called bargain for the public Medicares we have now, perhaps, they're not feeling the love that they once felt. So what do we do about this situation where we can't seem to move forward because any kind of critique of public Medicare seems to let in the argument that thus we should simply privatize the healthcare system rather than improve it? Is there some mechanism or some way of dealing with this, which I think many of us encounter?
Yeah. Well, I think the first mechanism is to reframe the issue. And I know that's hard because you do get used. I know that in some of my statements about the current weaknesses of the system, it's been used by people that are arguing in favor of privatization and against the very principles of Medicare. And I've always had to correct them. I've always had to come back and explain the position, which is very different than ours. But the reframing is as follows. There are only two kinds of privatization. One of them is passive and one of them is proactive. In fighting the proactive privatizers, those that feel that we need to shrink universal health coverage to allow greater private funding and private delivery, but particularly private funding, there's only really one solution, and that is to be proactive in terms of bringing things in. And virtual care is largely private, privately financed, privately delivered. But if it's brought within the rules of Medicare and properly regulated and governed, it takes on a very public character. And second of all, it allows for, there's nothing stopping some public delivery or some, what I would call nonprofit delivery to enter the picture. But if you don't do that, you will have an ever expanding private sector that begins to offer more and more Medicare services, with everybody pretending to look away and ignoring that, or defending the remaining Medicare system that's left.
Right.
The whole time it's being undermined. And so the only way to deal with that is to reframe this and say, no, this isn't about public and private delivery. This is about public governance, public funding, and a public set of rules. And we need to be proactive on that front, and we need to encourage at times nonprofit delivery, whether it's governmental or not, nonprofit delivery in some sectors, because those sectors would benefit, like long-term care. I mean, we've demonstrated in the pandemic, we've seen how for-profit care in Ontario, for example, in long-term care, has not been particularly great. But at the same time, we've seen how publicly managed long-term care in Quebec has not been great.
Yeah.
We need to fix both problems.
That's
and
true.
One of them is, allow more nonprofit delivery in both places.
Yes, absolutely. So I think we'll finish with the last question from Amy, which is around your expertise and comparing different healthcare systems around the world, Greg. I mean, of course, we still are in love with public Medicare, but if you could teleport in another healthcare system into the Canadian milieu, which one would you pick? Which do you think is the best performing healthcare system in the world at the moment?
Short answer, none. And you go to people in those countries and they'll all say the same thing: their system sucks. And they're dissatisfied with aspects of it. And even in a system that has fairly high satisfaction ratings like Switzerland these days, they're still very unhappy about certain dimensions of that system. So what this is really about is figuring out what are the strengths of some systems and how you might import the lessons to be learned from that sector of healthcare into your system. For example, long-term care in the Netherlands, and using the lessons from that from Canada, because Canada seems very, very behind when you look at the long-term care system in the Netherlands. And by system, I mean the homes and the way in which they're run, et cetera. If you want to talk about attacking the queue and wait lists, there's no point in going to a social health insurance system because there's excess capacity, but they're narrow they're narrow and they don't do other things very well. And that's, they basically protect the money that goes into that system, but it's not a very effective way of doing it. But, looking at other dimensions of that system that work really well, but not looking for them for lessons on wait times, but looking at, for example, Britain and a few other countries as to how they were able to reduce wait times so effectively in some areas. And then, I'd want to, if you're talking about, for example, primary care, which you raised, and I agree, it's absolutely critical. There again, I would want to look at what goes on in a place like the UK, where it's seen its primary care improve quite dramatically over a number of years. Even if other parts of the system are not great, that is clearly an area where they've made significant improvements in how we might go about doing that. So I do not see one system as being superior, but you have to bring a lot of judgment in terms of understanding where lessons can be drawn from exemplary sectors in which systems.
It seems, a very complicated and difficult agenda to have, right? To be able to figure out the most appropriate reform to be adapted, and then to adapt it to the specificity of our disaggregated federation, and then to somehow to also figure out, its survival factor. How do you make sure that whatever you put in place will survive and not become worse than the problem that you started with?
Yes.
So it is a big challenge for health policy people across the country, and I really think we need to figure out some better mechanisms than we currently have to actually figure out solutions. So
yeah, and I do think that the capacity within the provincial ministries of health is limited, and too limited for the task ahead, and they will. That has to be seriously considered. I think that their planning capacity is very poor at this stage, and the ministries of health in the provinces are the stewards of not just our Medicare system, but the mixed system as well. And you need tremendous capacity to be able to create a system that will be in the best interests of all Canadians.